Hello, my name is Stephanie Blank, and I am a gynecologic oncologist. I'm the director of gynecologic oncology for the Mount Sinai Health System. And I really enjoy speaking to organizations such as the Ovarian Cancer Research Alliance. This reminds me why I do what I do. So thank you so much for the invitation to be here today. I am speaking about rethinking platinum resistance. These are my disclosures. So here is the agenda of what we're going to be speaking about today. We are going to speak about why are we even having this discussion? Why are we discussing platinum resistance? We're going to speak about issues with the definition, and we're going to speak about why we need to rethink this concept. This talk is a little bit different, I think, than some of the other talks you're going to have during this conference. I saw the agenda. It is for the conference, not for my talk. I saw the agenda for the whole conference, and you really have a star-studded lineup, really brilliant minds you're going to be hearing from. And they're going to be speaking a lot about the latest and greatest things that are happening in the field. And you're going to hear about a lot of drugs, and you're going to hear a lot of data. This is going to be a little bit more of a philosophical talk, if you will. And it's going to be basically a little bit of a different way of thinking about how we think about ovarian cancer. I guess that's a little bit meta. So again, a different way of thinking about how we think about ovarian cancer. Let's start first about talking about platinum chemotherapy. You probably know about these. These are basically generally with ovarian cancer. We're talking about cisplatin and carboplatin. These are in the class of chemotherapy. They are alkylating agents. These are the backbone of ovarian cancer treatment. These are really important, and there are thankfully a really high response rates with frontline treatment of using these agents. The one we used, the first one that was used was cisplatin. This one was started to be used in like 1978, and then it was transitioned to the sort of the kinder sister carboplatin in 1989. That was approved, but these are very highly used. Every patient with ovarian cancer who's had chemotherapy has received platinum, and it is a fine drug. See here, fine platinum. I wanted to be very clear here that we're not rethinking platinum. Platinum is good. We're rethinking platinum resistance. Platinum, again, is a very good drug. I would say it is the gold standard in chemotherapy, but that doesn't make sense because platinum is finer. It's the platinum standard. It's a really, really good drug. If you remember, 2 years ago, there was a drug shortage. Platinums were in shortage, and this affected people with gynecologic cancers and ovarian cancer, of course, more than other people because we use so much platinum. It is such an important drug to us because it is such a good drug. And we use it a lot, especially in the first line. And I want to just also make it clear that the entire concept of platinum resistance is related to ovarian cancer recurrence or progression. If you've never had platinum, you do not know if you're platinum resistant or sensitive. So it's really somewhat teleological, if you will. It's basically starting from the end. So this is the prior paradigm. Again, this is how we used to think about platinum. Bear with me here. It's going to take me a little bit of time to get through this slide. So in the past, this is how we thought about platinum. A patient in general would get multiple lines of treatment, and there would be shortening intervals between treatment. So this is, I made this. It's a little sloppy. I know it's a little bit. So this is basically a graph of amount of disease, and this is a graph of time. So at the very beginning, and these little triangles are symptoms. A patient would show up with symptoms of disease and have surgery, and then she would start her first line chemotherapy. And this is this color because this is platinum. So she would start her first line. She would get her surgery and have her first line chemo with platinum. The amount of disease would go way down, and then she would have a long time not on any treatment and no disease, and then most likely, unfortunately, it would recur, and it would have been a good amount of time, and she would get another line of treatment, also platinum, respond to that, decent amount of time, symptoms again, and chemo. Again, it had since it had been a decent amount of time, more platinum, respond again, but there's still some disease there and would come back in a shorter amount of time. And then she would be at that point be considered platinum resistant. And then she would start getting non-platinum chemotherapy once she was deemed platinum resistant. And the thing of note here the point I'm trying to make with this graph is that once you stop responding to platinum, you start really not responding to things on down the line. And basically, you never really are without disease again. And your disease sort of grows and grows. And it's almost like a harbinger of worse things to come. So this is basically like the old way of thinking about platinum and platinum sensitivity. So these are the definitions of these. Again, this is the old way of thinking about things. And these terms are still used. I don't want to imply that they're not used, and you will hear them, but we're talking about why we need to rethink them, but I figured we need to talk about what they are. So the definition of platinum, whether you're sensitive or resistant, it basically starts from the day that you last had a platinum. So and we literally use the exact date. It's not like we say August 2025, we will say August 15th, 2025. So it basically starts from the last day that you had platinum until you have disease progression. And you're considered platinum refractory if your disease grows while you are on chemotherapy. It's not you're not platinum refractory, your cancer is platinum refractory. And then you have platinum resistant disease if your tumor recurs less than 6 months after you complete the platinum. You're partially platinum sensitive if your tumor comes back within 6 to 12 months after platinum completion. You're fully platinum sensitive if it comes back more than a year after platinum completion, and you're platinum agnostic if it's not yet known. Nobody uses this term, so don't pay any attention to it. And this is a little graph just short of showing that you're platinum refractory again if it grows while you're on, or this is less than a month after, resistant, and platinum sensitive. But sort of a better way, and the way people really think of it is in a binary fashion. You're either platinum resistant, or sorry, again, I shouldn't say it this way. A patient's cancer is either platinum resistant or platinum sensitive. You recur less than 6 months from your last platinum, your disease is platinum resistant. Your cancer comes back more than 6 months from your last platinum, your disease is platinum sensitive. And that's how we think about when people would think about the classification, this is how it's designed. And if you're at the 6 month part, you probably would go into the platinum sensitive category. And why was this done, or why is this still done? One of the major reasons why this is done, it was a categorization used for a lot of clinical trials. And the reason for that is because in general, some of the statistics could be modeled better that way. It helped guide treatment choices in general. If somebody's cancer came back greater than 6 months from the last platinum, the next choice of treatment would include a platinum. And if it came back less than 6 months from the last platinum, it would not include a platinum. And this was just an easy way to think of things in sort of yes, no categories. So how is platinum resistance determined? There's two sort of situations for this. So one is detection of disease growing, of progression during treatment. And the other one is detection of recurrence during surveillance while you don't have anything going on, and basically trying to see if something comes back. So I'm going to start with the easier one of this, and that is progression while on treatment. So this is assessment while on treatment. So basically, anytime you're on treatment, these are the things that I would say you should think about, and then I'll kind of talk about assessment while on treatment. So first of all, what am I getting? People don't always know what they're getting. So what drugs am I getting? What is the intent of the treatment? And how are we measuring response? This is what I sort of even teach my trainees about, what you need to think about when you're thinking about chemotherapy. So if you're on a platinum-based regimen, what what is the patient getting? What is the intent of the treatment? Is it curative or not, basically? And then very importantly, when we're thinking about this platinum question, how are we measuring response? Clinical symptoms is very obvious. So if a patient has, say, ascites, is the ascites getting better? Are we measuring response by CA-125? That's, of course, the blood test, the tumor marker. Are we measuring it by a scan? So sometimes we talk about somebody having measurable disease. That's generally what we're measuring on the scan has to meet a certain size or be measured in a certain way. Sometimes it's not big enough that it meets that criteria, but it still can be evaluated. Say something like ascites can't really be measured, but it can be evaluated. And how often do we plan to do so? Like, we're not getting scans every week, for example, just like you don't stand on a scale every day. It's not that useful if you plan too often, but that you sort of need to have some sort of sense of how often you're going to do that. But the reason why it's important to know these things is because when you're getting these assessments is how you're going to figure out when you progress. So if one is not checking scans until 6 cycles, and a patient doesn't have any symptoms and doesn't have an informative CA-125, progression will not have happened until 6 months. I don't know if that makes sense. So basically, if you're only measuring progression by a scan and you don't get a scan for 6 months, you won't be able to tell if you've progressed or not for 6 months. So it's really very arbitrary. So which date will count as the date of progression? So what I'm saying with this is if you're measuring a CA-125 every 3 weeks while you get your treatment, and the CA-125 is going down, but then at the 4th cycle starts going up, and then you say, oh, let's wait another cycle, and it goes up a little bit more, and you check a scan at that point, and it does show that the disease has grown. Is the date of progression the date that the CA-125 went up, or the date that the scan showed something grow? Or if you decide that you want to wait a little bit longer, look how you've influenced the date of progression. And this is a reason why on clinical trials, if you've been on a clinical trial, the dates of the scan are so closely monitored, because it really can influence these findings so much. So basically, this is one of the situations where these things are a little bit fuzzy. So let's talk a bit about surveillance. Surveillance is when you're not on treatment and you're being followed by your doctor. So this is these are the guidelines for following somebody with ovarian cancer while they do not have treatment. And this is the most up to date. These are going to be reissued, by the way, so there will be some more up to date ones. And you might look at this and say, wow, this is not how I'm being followed. Because, for example, this here says that CA-125 is optional. And that is based on best evidence. And in Europe, not everybody gets a CA-125. In this country, most people do. But you can see it, for example, in years 0 to 2 after diagnosis, symptom review and examination every 3 to 4 months, with CA-125 optional and no regular radiographic imaging. A lot of people don't necessarily practice this way. There is not data to support getting scans every 3 months, for example. If you do suspect recurrence, it is appropriate to get scans and CA-125. But this is one way to practice. But I'm going to show you now, like, how do we define recurrence? Same sort of questions that I was talking about with progression, but do we base it again on symptoms, elevation of CA-125, scans? And if you find something on scans, you need to confirm it with a biopsy or not. So these again are the same types of questions, but it's even a little bit more tricky when you're talking about surveillance. I wanted to go through a couple of case studies with you to put all of what I'm saying, really to show you practically what it might mean. So these are some case studies. So if you have somebody who sees her doctor every 4 months rather than every 3 months, she is more likely to remain platinum sensitive. Let me explain this. So if you have somebody who sees her doctor first follow-up visit after completing her frontline chemotherapy, she's at 4 months, she's fine. She goes to her next visit, there's a bump in her CA-125 and she gets a scan, there shows progression. She's 8 months out, she's platinum sensitive. The other patient goes to see her doctor at 3 months. She's fine. She goes to her next visit, bump in CA-125, gets a scan. Let's say she comes a couple weeks early for her 6 month visit, and she ends up getting the scan 2 months earlier than the other one. It's just basically she could really fall into a different category just because she schedules her doctor's visits at a different time. Somebody whose doctor gets scans every 3 months, she maybe is more likely to become platinum resistant sooner. She's getting much more often looked at, so things are going to be found quicker. And let's say you have a bump in your CA-125 at 5 months, for some reason you got it then, and you're going out of town for 6 weeks, so you schedule your scan later, you can go from being platinum resistant to platinum sensitive. And so what does this mean for you? Is this going to cause you to get a treatment that won't work? Are you just barely platinum sensitive, or deny you getting a treatment that would have worked? Maybe you really are platinum sensitive and something happened that made you not be able to get that. Are you not being denied entrance to a trial that you really would have benefited from? Or are you being kept out of a trial because of the wrong designation here? Here are some more case studies with a timeline there that maybe will be a little bit more visually demonstrating. So the first one here is a patient who does not get regular CA-125s or scans. And so her recurrence is diagnosed when she first has symptoms over here, again, a little bit on the later side. This patient, and this finishes her treatment here, just like all of them do. And she's getting regular CA-125. So she gets regular CA-125 that goes up and she gets imaging. And that's when her recurrence is diagnosed. This patient finishes her treatment at the same time. Her tumor never made a CA-125, which of course happens sometimes. Her doctor gets routine imaging. So her recurrence is picked up when the imaging shows something. It's not a false negative CA-125, it just was never elevated. And then this patient is basically getting CA-125 and it rises and the imaging is negative. It's not really necessarily false negative, it's just negative imaging. I personally would not diagnose this as a recurrence based on imaging, based on a marker alone. I think you really need to have a finding to treat. I would not treat a number. So I personally would not call this false negative imaging, and I would have moved the recurrence out. But you can certainly just see, depending on how you're being followed, the timing of your recurrence can be different. And this does not necessarily mean the recurrence on a purely biological level happened at a different time. It can just be picked up at a different time, depending on the method by which you're looking. And oh yes, and this is my picture of being arbitrary. So this is basically a demonstration of the problem with labels, and platinum resistant is a label associated with ovarian cancer, and patients with the same label can respond very differently, and that's really the problem with labels. As I said, the word resistant is very emotionally heavy. I think if a patient hears that her cancer's become platinum resistant, it's almost like stepping into another room, another whole class of patient. And I think we need to really move away from that because it can create unnecessary fear. And I'm going to go into that a little bit more, but it's really a spectrum, not a line. I think that's something that we need to remember. 5 months versus 7 months can look absolutely the same biologically, and real life doesn't follow strict cutoffs. So that's something we need to remember. You can have the same label with different outcomes. You can have a recurrence at 5 months who has a great response to the next therapy, or recurrence at 7 months who does not have a good response to the next therapy. So labels don't really predict very well. And in essence, This is oversimplifying complex biology. So this platinum sensitive platinum resistance was just a way to try and make complexity very simple, and it doesn't necessarily really work. We have tumor genetics and environment that matter. We have the immune system that plays a role. It's not just the timing of the recurrence that's going to determine everything. And we're really in a new era of ovarian cancer where we have new treatments and we have more tools than ever before. So treatments are not only defined by a patient's tumor response to platinum. Here's a really important way that we now define tumors. And this is not teleological. This is from the beginning. We recommend, as you know, that every patient with ovarian cancer gets genetic testing, and we recommend that everybody gets their tumor sequenced. So when we do this, we can look and we can find that, about 20% of patients are going to have some sort of BRCA mutation, and another 30% are going to have some sort of mutation that makes their tumor homologous recombination deficient. These are all mean that all these people's tumors have some issue with single strand DNA repair. And so this is something that can be targeted with tumors. These patients' tumors actually tend to respond better to platinum, but it's not only platinum that we're talking about here. And then there are a whole bunch, half of the patients actually have tumors that are homologous recombination proficient. And this is actually a way that we're thinking a little bit more now about categorizing patients, but it's not necessarily it's not necessarily based on how they responded to a treatment. It's basically figuring out how to choose treatments from the beginning. And that's a totally different way of thinking about things, right? So again, this is an era where we're looking at people's tumors being sequenced or stained to define them. We're looking at drugs like antibody drug conjugates. These are the ones that we're using a lot are those called mirvetuximab. We're looking at one that I'm not going to say the whole thing because it's very long. I'm going to say TDXD. We're looking at other antibody drug conjugates that are not yet FDA approved. We're looking at immunotherapy. We're looking at genetics. All of these things now define how we're treating people. And again, it's not only platinum. So here are some really important drugs in ovarian cancer, and the response to these drugs are not determined by prior response to platinum. Bevacizumab, mirvetuximab, trastuzumab deruxtecan, that's TDXD. Checkpoint inhibitors, combination therapies, and here's a combination that I use a lot, and clinical trials testing new strategies. And what combines all these? What's similar about all these? These are all targeted agents. So when you're targeting something specifically, platinum doesn't matter. So in the past, if you remember what I said at the very beginning, response to platinum predicted your response to the next drug. If you had not responded to platinum, it was much less likely you were going to respond to the next thing. That is not true with these drugs. So that's why this whole binary thing of platinum sensitive versus resistant is much less of an issue. So again, we have all of these drugs in ovarian cancer now. Back at the beginning, when cisplatin first became a thing, we only had these drugs. Look, we had so few drugs. Now we have so many drugs. When carboplatin was approved, we had so few drugs. We have so many more drugs now. And actually, from this red line to the right, all of these drugs are targeted therapies. So we have all these targeted therapies. And as I said, the PARP inhibitors are slightly different, but platinum response does not predict response to targeted therapies. Platinum resistance does not mean no options. This is really important. I'm just going to say it again. Platinum resistance does not mean no options. Many effective treatments exist after platinum. Again, look at the other side of that line. Really important. This is an era of personalized medicine. We have genetic testing that guides choices. We have molecular profiling of tumors. These have changed. We're like in the Renaissance era of medicine. And those are really the reasons why we can match the right drug to the right patient at the right time. And platinum is good. Platinum is great, but it's not the only thing that we have. Okay, I just like this picture. So I was going to say that we're turning platinum, the concept of platinum on its head. We're not. I don't want to imply that platinum resistance means nothing. It still means something, but it doesn't mean everything. And that's where we have to really get over that. I think that there was a time when it did really mean everything, but it does not mean everything now. It doesn't. Um, Patients are doing well after having that resistant label. Great. Hope is real and is grounded in science. This is not magical thinking. I'm not like blowing something up your what. I'm not misleading you. This is real. So how did we get here? Research is breaking down old categories. There's more of a focus on biology and less on timelines. And the future is flexible and tailored treatment. Again, how did we get here? We got here through research. The Ovarian Cancer Research Alliance. Research is in the name. Research is so important. And again, I told you I have so much gratitude for a foundation like the Ovarian Cancer Research Alliance. The Ovarian Cancer Research Alliance, or OCRA, has programs that specifically can get you involved in research. There's the Clinical Trial Navigator program. There's free genetic testing, which is really important, as well as the Staying Current program. So all of these can keep you at the forefront of research. And through research, advances are made. I would, even if I gave this talk 5 years ago, it would be a different talk. And we have so much that are moving things forward. So here is your take-home message. Platinum resistance is a historical concept, not destiny. Many treatments now work regardless of platinum. Long-term outcomes are less tied to this label. Progress is rapid and ongoing. I thank you for your attention and have a wonderful day.